here. Okay, let me share my screen.
Is anybody else seeing a video of Stanford Medicine Children's Health playing in the screen?
Nope.
Weird.
Okay, can you see my screen now? It says
Yeah, we can see your slides. There's a box over the right-hand side though, Daniel.
yeah, okay, so that's one of these little silly things here. Okay, how about, is that smaller now?
Yeah, it's much smaller.
Okay.
It's still there.
Somehow showing the slides and the picture kind of with the same issue we've been having in the past. So I must be doing something wrong here. So I think we'll go ahead and get started. I touched on some of those pieces today. So out of our Project Unify group, there were, as I said, a bunch of folks who were involved with multiple different aspects of the work. And we concentrated initially on some of the Integrated Care for Kids program, which came out of the Centers for Medicare and Medicaid Innovation, with the goal of developing an alternative payment model, connecting Medicaid and child welfare, behavioral health, education. And in order to sort of describe what we were talking about, the group came up with this pinwheel diagram, looking at putting the individual in the center and then thinking about the various different programs, whether or not they're health or judicial or education, that were touching the family and the systems that were involved in the individuals. And I think in some ways this presents the complexity of the work that we're trying to do on behalf of individuals. People, as we know, who are involved in multiple systems have a lot of work to do to coordinate services and supports. And the most important thing is being able to securely and responsibly and accurately share information to really coordinate care for folks who are involved with multiple programs. And as we know, one of the more challenging components of that is getting consent across those various domains, given the various and sundry types of consent and requirements we've been hearing about all day. Fundamentally, I think what we need to do is think differently about the models and tools and competencies across the various areas, because healthcare is very different than education, which is very different than judicial or justice, and public health and public safety. And so a lot of the work over the last couple of years has been to really think broadly and deeply about this work. And that's really represented by the participants. And this is just a small segment of the folks who have been lending their proverbial shoulder to the flywheel over the last couple of years. Many other people have been involved, but these organizations, I really want to call out and to say thanks to them for showing up and adding and contributing to their knowledge over time. And as you can see, it really does span a broad sector. So the problem that we're facing here around consent is pretty obvious when you start to look at the various programs that are trying to share information or might have a need to share information amongst themselves. The permutations are almost unfathomable in terms of the unique individuals. But this is really in many ways what people face every day, whether or not it's children and family services or courts or student information or healthcare, WIC or SNAP or child welfare. There's a need for the ability to share that information securely, of course. I'll call out a use case that we developed, actually more of a scenario over the course of a couple of years under, as I said, the Integrated Care for Kids. We really spent some time thinking about creating a scenario that could embody virtually all of these. And we came up with a scenario which we call the Thompson family, which includes a variety of use cases, personas. And within that scenario, we've created a number of demos, and Brian Hanspicker, who's on the call, really led that charge, and we'll talk about a little bit of that later. Point of me mentioning that now is the fact that there is actually there's a use case, actually a scenario that includes use cases that actually can really represent the complexity of the kinds of problems and issues that we're facing out there. And so I mention that because there's a lot of good work that's out there that we can build on. Just a few more slides here about the basis for consent service utility. The problem, I think we've talked about that, I've heard about that already a lot today, is the ability to obtain and manage consent is typically not user-friendly. It's hard to understand. It's often paper-based, broadly distributed in the community. everybody's got their own consents, and it doesn't engender trust. I think this is safe to say this is true for most any and all of the situations out there. Our goal in bringing this group together is we want to put data, we want to put people in the data driver's seat. And there's nothing really probably more equity focused than providing everybody the ability to share or not share or to revoke their consent. We want to help helpers help. I heard that that's not unique, but I thought it was really representative of what we're trying to do. Those people out there trying to connect the dots and provide services at the granular service level. And importantly, building trust, improving decision-making, and enhancing care coordination is at the foundation of this work. Now, I want to see, this is about a 1-minute video. I want to share this because we talk about the consumer or the voice of the consumer. This is work that was done by Topo's group that has done a lot of work in this area. I'm going to play this, and I hope I did enable it on my sharing screen, so you should be able to hear about it. There's 4 different people speaking for pretty briefly. So let me just play this and then I'll come back to you at the end of this. Here we go.
I know a lot of people in my life have been hesitant to go to the doctor just because of that reason. They're scared what the doctor will know, what they'll share. But if there is a confidentiality, trust, or information entrusted into them, then they'll feel more comfortable coming forth.
Okay.
And then that way the problem can be solved.
That would definitely help with the privacy concerns. I mean, if I had a choice, just having a choice is definitely empowering.
That new, I guess, concept, I hadn't heard of, the information trust. And I guess that's something that, you know, if it is new, new idea, just getting more information and letting know, this is how it's going to work and how it's going to benefit the providers that help us to better take care of, certain needs.
I think if you have the information presented to most people, hey, we're using this information to try and improve our services, then they're probably going to be maybe a little bit more receptive, but it's still good to have that option for someone to opt out if they choose to.
Just a few voices. It's always great to hear what people think about that. And that's been my experience, and I think a lot of ours experience. If we ask people to present in a way that's understandable, people are pretty willing to participate in this. So basis for a consent service utility. Yeah, the solution that we've come up with or thinking about here is really an open source, open API, standards-based, customizable solution to identify and capture, in some cases, capture the consent to be able to manage and revoke permissions to share private information across all relevant domains. So trying to stuff as much as we can into one sentence. The idea of a utility, I know that from our conversations, there's been a lot of different discussions around what that actually means. The way we're thinking about it is something that can be replicated or provided as a service. We customize its core elements to meet the unique needs of various jurisdictions, because we know the legacy infrastructure, the laws, interfaces, rules engines all have to be tuned to the individual communities. Thinking about it very locally, so that we can really leverage the investments without having to start from scratch. And I think that's one of the things we really heard from folks a lot was, how do we not recreate the wheel every time? And that's the major goal of it. Again, from a consent utility perspective, think of the electrical grid, different people contributing over geographic distances, but maintaining the local support of it locally. The CSU will, in a sense, be a registry for storing or identifying all consents in a specific jurisdiction, for authorizing users, and for providing notification to those people who can use it. Ideally, there'd be a common interface that enables informed consent to be obtained, so that people have be like a family of consents that would be applicable, that would adopt and utilize applicable state and federal privacy laws, policy codes, etc. A configurable backend or a rules engine to ingest and filter and segment the tools, and then such that it could be replicated by customizing its core elements, which I've said just previously. So to build on the infrastructure and to be able to build that over time. Our proof of concept objectives are to develop over the next couple of years a minimally viable product with a few data elements using synthetic data. And we'll talk about this in just a minute. I'm going to ask Kathy and Connor to talk about the 2 use cases we've identified. Into the second year, we would transition from a MVP to a proof of concept. And actually, there's no actual data shared at this point in time. We're thinking of this as sort of the front door before data sharing happens. You need to obtain the consent. Then after that, data sharing can occur. We need to engage people with lived experience to make sure we're creating something that's understandable and that is reflective of people's cultural and language experiences, building a configurable rules engine, and then importantly, we need to prove out that it actually provides value so that this can be embedded into public sector funding, whether or not it's Medicaid funding or HIE funding or whatever it might be, so that there's continuity and sustainability. And that's one of the reasons that one of our key partners here is the Linux Foundation for Public Health. So we have a home for this to live beyond the particular projects. And we're anticipating that this work would happen over the next 4 years or so in 3 to 5 sites. With that, I want to turn it over to Kathy and Connor for a few moments. Kathy, over to you. You want to talk a little bit about New York and the use case and what we've got sort of teed up there.
Sure, happy to. So working with the Bronx Equity Integrated Care for Kids program, we identified a use case where data is not flowing easily now because consent is difficult to get and move around among the parties that need to know where the consent exists. And that use case is centering around the early intervention program, and which is basically administered by the New York City Department of Health with oversight from the New York State Department of Health, and involves pediatricians, childcare providers, and schools who all need to know things about what's happening with that child and who often do not get the information that they need to get. And so the pilot that we're going to be doing, which is going to be enabled by my HIE, the Bronx Rio, will involve basically, simulating the collection of consent from the parent when the child starts in the EI program, for EI to share their assessment information and their plan with the child's pediatrician, with their daycare provider, if it's preschool child, which is generally where EI falls on the age spectrum, and to transfer that information to the school system when the child gets to be of age of entering the school system, so that the school system knows the history of that interaction and the plan that had been implemented and the services that might have been getting provided, so that as the school system plans for the ongoing needs of that child, they can know that they have the information they need because we enabled getting the consent from the parent at the point of enrollment in EI. So we're talking with all of the various agencies involved at this point. We're, finishing up defining our requirements for what this really has to enable. And hopefully we'll find some funding and be able to get this pilot project underway pretty soon.
Thanks. I just seeing a note for there being 8 minutes left. I think that's a little shorter than I expected, but over to you, Connor, if you give us a view from Hennepin.
Sure. Hi, everyone. I'm Connor Johnson. I'm the Model of Care Coordinator for Hennepin County, the county around Minneapolis, Minnesota. And we are really looking to do a universal informed consent work around a population we've identified that are people who are experiencing homelessness or housing instability in our county healthcare system. And how do we better understand the housing services and the care coordination and really do universal consent to better understand care coordination across our county systems. So what we're looking to do is pilot with 2,600 individuals that we've identified who are experiencing housing instability and homeless, who are part of our county health plan, our local HMO, who are also part of the healthcare system and seeking services in our healthcare system. So we're really starting with that group to really look at and learn how we can pilot universal informed consent for better care coordination, better end user experience, and then take some of those key learnings or a lot of those key learnings to other populations across Hennepin County. So that's our high level what we're working on right now.
Thanks, Connor. Thanks, Kathy. Obviously, a lot going into that as well. In addition to the two sort of shovel-ready sites with New York and Hennepin, other folks have come to the table who are definitely interested, wanting to be learning partners along here. You can see from the list, there's quite a broad group of folks, and with various different kinds of perspectives. Our goal is to not make this exclusive, but to sort of layer around it those that are at different stages of interest, so that we can not only build the knowledge, but also spread it broadly and to learn, continue to learn from one another. And with that, Brian, let me hand it over to you to give a little bit of the technical overview here, and we'll see how much time we actually do have left here. But according to my watch, it's 3:29. So
sure, I'll see if I can go through it rather quickly.
Thanks.
Regarding consent technology, we stand on the shoulders of giants. The healthcare standards world has spent a couple of decades trying to crack the nut of security, privacy, and consent, including the definition of many different standards, including the FHIR consent resource, data segmentation for privacy, the HL7 consent service functional specification. In addition, funded by an ONC LEAP grant, Mohammed Jafiri and Dwayne Dakota architected and implemented an open source consent decision service, also known as LEAP CDS for San Diego's HIE. It was designed to support social care as well as healthcare data consent, but they were only able to implement support for the healthcare consent during the grant period. Mohammed, by the way, is leading one of the other breakout groups this afternoon, and I'm sorry I'm not able to listen in on his presentation. Next slide. With LEAP CDS as a foundation at the heart of the unified consent service, but you'll note that consent management has been moved around to enable it to use consent discovery, so that a single consent management app can be used across many different consent stores, many different systems that store sensitive information without having to have a priori knowledge of where those stores might be. We've also added in explicitly identity management in the form of the semi-external identity attestation and validation component. Diving deeper into the functionality provided by consent discovery and consent decision services, we see a more complicated model, largely in order to better understand exactly where existing technologies might fit in to a model for a consent service utility, albeit. So we have things like consent enforcement service, but it's generalized to authorization enforcement. We still have consent decision service, now computed authorization. And we've explicitly called out identity matching. Consent discovery then has added in record location and record access. Our hope is that we now have a more complete model for consent with all of the associated required services, which then allow us to do a mix and match of which technology is most appropriate from which area, from which provider. Next slide. So I should point out that as part of the giants whose shoulders we're standing on top of, consent services are not done in isolation, but rather they're part of and leverage a broad set of industry standards and consortia work on many different issues associated with identity, privacy, consent, security, including all of these organizations and then some. Next slide.
We are out of slides.
And we are at discussion and next steps. So
Yeah.
Good timing.
Actually, there's one thing I wanted to just reinforce or underline in this slide, Brian, which was, for those organizations that don't have an existing consent mechanism, that we're considering how to, and these are particularly CBOs, community-based organizations, how do we help make sure we can both aggregate, store, and then share that information where it might not be an EHR. And you've identified that in some of the consent stores.
That top consent store, the one that says CSU consent stores, is intended to be local to the consent service as opposed to specific to individual EHRs, case management systems, student information systems, et cetera. So we've got the mechanism of being able to be the consent store for any systems that don't already have that built in, while at the same time acting as a proxy for those systems that do already have consent.
Thank you. I will say that for those who are interested, there are plenty more resources on the NIC Hub, as well as I'm sure ONC has a lot of materials there. So I'm going to stop sharing and open up the floor. I think Lauren has a question.
Yeah, I'm just wondering if you could speak to the key challenges from a technical interoperability standpoint for just enabling, I think it gets more challenging, obviously, when we're outside of kind of the pure health space. Maybe we could just speak to the health space, so enabling kind of this system.
I will turn that to my technical partners, Jim or Brian or Kathy.
I think maybe I understood you're asking, how does this apply to non-healthcare information? And we are looking at how to extend the rules system that's been defined for determining authorization of sharing healthcare information, and how it needs to be extended or modified